morning, good afternoon, good evening po sa lahat. Saan man pang panig kayo ng mundo naroon. Welcome po to our 214th episode of the Health Updates webinar series. Thank you for being part of our credible online community. And to all those who have just started to follow us today, welcome. And we hope you will understand po and be able to apply whatever learnings po that we can get from today's webinar. Our topic for today, breast cancer. It remains a significant public health concern worldwide, pati na rin po dito sa Pilipinas. At sa ating episode po for today, we'll be examining breast cancer epidemiology sa Pilipinas, key statistics, obviously, risk factors and trends, breast cancer incidence, mortality rates, disparities in terms of healthcare access, at gaano po ba kaimportante at ang kahalagahan po ng pagkakaroon ng timely diagnosis and treatment. Obviously, our focus will be more on prevention strategies. So, lifestyle modification, healthy diet, regular physical activity, maintain a healthy weight, all of these can help reduce breast cancer. We'll also discuss po ano po ba ang papel, what's the role of hormonal factors and genetic predisposition. Obviously, we've heard a lot through our colleagues, through our families, friends, relatives, ano po ba na idudulot or na i-contribute po ng pagkakaroon po ng genetic predisposition sa pagkakaroon po ng breast cancer at gaano po kaimportante ang maaga pong intervention at maaga rin pong mga risk assessment. We'll also be discussing the importance of breast self-examination, yung pong clinical din po na examination, mammographic screening sa pag-identify po ng breast cancer at early stages. And we'll be addressing, if we have the time, hopefully, what are the common misconceptions and challenges associated with screening programs here in the Philippines and how to provide guidance on best practices for early detection. And then finally, when it comes to treatment, lumpectomy, mastectomy, obviously will include adjuvant therapy such as chemotherapy, radiation therapy, other targeted therapies. And then later on, if we're talking about advanced stages, the role of palliative care in managing breast cancer symptoms and improving the quality of life. This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Friday, and also my pleasure and honor to host this program together with one of our program stalwarts, Dr. Stella Mariase. Ma'am Stella?
Good afternoon, Doc Raymond. Good afternoon, and welcome to our participants here in the live broadcast of the Zoom webinar, and all those watching via YouTube channel, live streaming via TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and TVUP Signal 101. Our panelist for today is none other than Dr. Sheila Macalindong and also Professor Bibeth Ortesa. Our new program is now called Health Updates. We have done a little bit of reformatting, but we maintain the same high quality and then leveling up to take a closer look at existing and emerging health problems in the Philippines and in the rest of the world. For this year, we want to get immediately to the heart of the problem, and so our program is now shorter. But sit back, relax, and listen to our very, very competent speakers, and we will learn a lot from them. Back to you, Raymond.
Thank you, Ma'am Stella. We're very, very excited na po to hear from our speakers. But before that, we'll be tackling po what we have week in, week out produce. And thank you again to the very hardworking team at the webinar of this webinar series, obviously comprised po from those from TVUP po. And to help us set our discussion into context, we always show this what we call person on the street video, just to determine their baseline knowledge on the topic at hand. The questions that we pose to our interviewees for this week are as follows. May kakilala ka bang na-diagnose na ng breast cancer? Ano ang mga treatment options na pinagdaanan ng breast cancer patient na kilala mo? Sa inyong palagay, gumagaling ba ang mga pasyenteng na-diagnose ng breast cancer? Paano ba nagkakaroon ang isang tao ng breast cancer? At sa pagkakaalam ninyo, anong edad po dapat nagpapascreen para sa breast cancer? At sa alam ba ninyo ay ang breast cancer ay sakit lamang ba ito ng mga kababaihan? Please watch this.
Yes, meron po. Family member.
Opo, hindi lang po kakilala, kundi ang nanay ko po.
Yes, definitely. It's my sister. But I was diagnosed first before my sister Sally. She was also diagnosed with breast cancer.
Nung nag-undergo yung family member na kilala ko, kinailangan niyang ma-confine sa hospital for around 2 weeks straight kasi may mga operations. Kung di ako nagkakamali, parang may mga tinatanggal na bukol.
So after nung malaman na may cancer siya sa breast, isang breast lang yung pinatanggal, mastectomy. So ang ginawa sa kanya is na radiation, katapos binagbawalan din siya ng maraming food na malansa.
It started with me first, I don't have any symptoms then, so it was just that by chance that I had my mammogram done because I was about to go home, for good from King Faisal, and then that was the time I was diagnosed with breast cancer when they get the biopsy and all in June 2017.
Actually, hindi ako sure. Pero yung sa case nung kilala kong family member, ay hindi totally nawala. And may mga maintenance siyang ginagawa. And if I remember correctly, parang every 6 months or every year, kinakailangan niyang bumalik sa doctor just to make sure na okay pa yung kalagayan niya.
Yes, I think gumagaling. Kasi yung mom ko na-survive niya, as in 15 years na-survive niya yung kanyang cancer. But she died of sa brain.
Oh yes, there's a lot of people now who really like a breast cancer patient like me, who are into remission and is getting well for as long as you eat to your medications and check up all the time. Yes, we do recuperate.
Yung mga ganyang bagay, hindi mo rin malalaman bigla-bigla Parang magulat ka na lang na kunwari nagpa-check up ka for other case, tas biglang ay may ganito pala ako. So better to check up from time to time. Kahit nga wala ka pang 20s, dapat regularly nagpapa-check up.
Parang bigla na lang niyang naramdaman daw habang nagwawali siya, parang masakit daw yung bandang breast niya. So hindi niya pinapansin, akala niya masakit lang kasi panay ang walis niya. And then nung hindi niya na matagalan yung sakit, pinag-check na namin kung bakit masakit. Doon palang nalaman, stage 3 na siya.
With mine, I think it's more on, it's in our family, like my relatives, like the sister of my mom. Little did I know that most of them had breast cancer.
Sa ngayon, siguro 50. Pero kasi yung nanay ko noon hindi nagpa-check talaga Parang wala pa nung time na yon. Wala pa nga akong alam na may chemo na noon kasi radiation yung ginawa sa kanya.
For someone who has cancer like I think like my children, I think they have to have it earlier, age 30 yes, especially when it's in the family.
Well, yung norm kasi, di ba, parang pag breast cancer, babae lang kasi nga daw breast. Pero ang alam ko, pwede mangyari yun sa mga lalaki, pero very rare case.
Sa ngayon, alam ko na hindi lang babae. Alam ko meron na rin cases na nagkaroon ng breast cancer ang lalaki. Kasi may susurin sila Hindi nga lang katulad ng suso ng babae na maraming mass. Ang lalaki may susurin. So, may possibility na magkaroon din sila.
Even men develop breast cancer. At first, I thought it was just for women. But then, like when I had one and into readings and some of the, my friends, they said that even men can have it.
Thank you so much, webinar team. So very, very important, especially the insights that we got. And I'm pleased that we're able to get different perspectives from our interviewees. Before we delve straight into the webinar proper We'll just have a few housekeeping rules. Again, as mentioned, all those who have watched at least 50% of the webinar duration will be eligible to receive their certificates of attendance. We have sent out all of our certificates of attendance for all 213 webinars. So please let us know if you have any questions or comments, and please email us at our up.edu.ph account. For our webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. Okay, to start the ball rolling, Ma'am Stella will introduce po our main speaker for today.
Our main speaker for today is Dr. Sheila Makalindong, who is a clinical associate professor at the UP College of Medicine, Department of Surgery. It's your turn, Sheila.
Good afternoon po. Let me just fix my slide for a bit. Can you see my slide po?
Yes, breast cancer basics, Dr. Sheila.
Okay, thank you. So good afternoon. So thank you for having me in this webinar. So my objective for this afternoon's presentation, for my part, will be to describe the burden of breast cancer disease in the country, as well as describe the clinical presentation and provide an overview of breast cancer screening, diagnosis, and management. So breast cancer management is really a very rapidly evolving field. So it is quite a challenge to sum everything up in 20 minutes, but I'll try my best. So the breast cancer is a very big problem in the country. It's the leading cancer site in the Philippines for both sexes combined, and it's the most common cancer site for women. Approximately 6 to 7 out of 100 Filipinos will develop breast cancer during their lifetime. I would just like to emphasize that breast cancer is not limited to women. 1 out of 726 men can also develop breast cancer. It is the second most common cause of cancer-related deaths for both sexes combined, and is the number 1 cause of cancer-related deaths for females. Approximately 2 to 3 out of 100 Filipinos will die from breast cancer. From this graph of incidence versus mortality for breast cancer in the Philippines and representative countries in Asia and in the West, we can see that our breast cancer incidence is actually lower than theirs, but the problem is we have a much higher mortality. One study cited that Filipinos with breast cancer living in the Philippines had a much lower chance of survival compared to Filipino breast cancer patients living in the US or their Caucasian counterparts. So from this, we can surmise that the problem with increased mortality of breast cancer in the country can be due to late diagnosis and the problems with access to appropriate and timely management. Now, as we know, majority of patients with breast cancer will present with a breast mass. However, it is important to recognize that some of them will actually not represent with a mass initially. So for the medical frontliners out here in the webinar, it's important that they don't always present with a lump. Other presenting symptoms can include nipple discharge or very subtle nipple abnormalities. They can present with breast pain, even abnormalities in the breast skin, a mass in the axilla, even arm edema, or even non-specific constitutional symptoms. No, sadly, we see many patients on their first consult presenting with masses that look like this. No, so it's almost criminal to not suspect breast cancer for patients presenting with these kinds of masses. Sometimes they can just present with a simple palpable mass. No, just as an aside, if we do encounter patients with ulcerated or fungating breast wounds like this, it's important to give them advice on, of course, wound care and also for tetanus immunization, because these types of lesions are actually tetanus prone. So sometimes, as I said, symptoms and signs may not be as obvious. They can present with nipple discharge as the first sign, and particularly worrisome would be nipple discharge that's bloody and spontaneous. We should also be on the lookout for subtle changes in the nipple, like nipple retraction or nipple inversion, and ask whether these changes are new onset or whether they are congenital. Often missed also is Paget's disease of the nipple. So this is characterized by red or scaly rashes in the nipple or nipple areola complex. And we can often mistake this to a simple eczematous or dermatosis, no? But some may actually represent already beginning breast cancer or yung Paget's disease of the breast. Some even more subtle signs would be retraction of the skin. No, that's why we emphasize when we advise patients or women for self breast exam to really be familiar with how their breasts look, breasts look like, the contour, etc., and to examine their breasts in various positions. No, with the arm at the sides, arm over the head, so that subtle changes like this can be accentuated. And then sometimes signs of breast cancer can be mistaken for breast infection, so particularly for young women. And this is problematic because this can lead to delays in diagnosis. So there is such an entity as inflammatory breast cancer. This is where the breast appears erythematous or very reddish, or edematous, no? So you have this typical podi orange or parang orange peel, yung skin of the orange appearance of the breast. So that should clue us into the possibility of inflammatory breast cancer. Oops, sorry. Okay, so again, to detect subtle changes in the breast contour, we should advise our patients who do their breast self-exam to vary the positions of their arms when examining their breasts, examine their breasts in front of the mirror, and really be familiar with how their breasts look like. It's also important for them to palpate not just the breast, but also the axilla, so they don't miss out on enlarged axillary lymph nodes. So again, just to bring home the point that most of the time, breast cancer will present as breast mass, but sometimes it can present with other things like changes in the skin, changes in the nipple, swelling in the armpit, and etc. It should also be important that we correct the misconception of patients that breast cancer is always associated with breast pain. In my practice, I often see patients who delay their consult even if they have already palpated the mass, because they would reason that it's not painful. So note that pain is neither sensitive nor specific in the diagnosis of breast cancer. Of course, in Western countries where there's a population-based screening, many of them get the breast cancer get to be detected when they are still asymptomatic. No, they're only seen in mammograms. In the Philippines, we don't see as much screen-detected breast cancer, but we do get them every once in a while. So it's important to be familiar with the suspicious findings on mammograms. So usually they present either as mass lesions or as calcifications like this. Now, so they appear as whitish dots on your mammogram. So not all calcifications are malignant. So it depends on certain patterns and configurations of these microcalcifications. So the findings on mammogram there would be this final report. Now they would issue a BIRADS score for the mammographic findings. So of course, this is not intended to be an intensive radiologic course, but definitely if you see a score of 4 or 5, then those are indications already for biopsy. Sometimes they come into to our clinic with the breast ultrasound. So suspicious findings on ultrasound look like this, no? Hypoechoic, meaning black lesions with very irregular borders. They tend to be taller than they are wide. So these are all the characteristics of a suspicious lesion on mammogram, and should also prompt a biopsy. So just some practical points, when we encounter a patient with suspicious findings on their imaging, whether it's mammogram or ultrasound, it's always important to correlate the breast images with your physical examination. Of course, we know that some of these tests, particularly ultrasound, is subject to a very high inter-observer variability. So they may put out a report of a very benign lesion, but if your physical exam says otherwise, your physical exam, it's a very hard mass with very suspicious clinical features, then you should still consider pursuing biopsy down the line. And if you have any doubts, then it's important to confer with your radiologist. And a common misinterpretation I see in my clinic is the interpretation of BIRAD 0. Sometimes clinicians are assured when they see a BIRAD 0. BIRAD 0 is actually not a negative result. It means it actually means an inadequate imaging. So you need to either order some more diagnostic tests or look at the previous imaging of the patient. And also, we have to recognize that mammography is not it doesn't detect all breast cancers, no. It can miss breast cancer in about 8 to 10% of the time. So again, just to emphasize that it's important to have that clinical and radiological imaging findings. Okay, so as we know, screening will allow for early diagnosis and better survival and outcomes for our breast cancer patients. Now, when to start breast cancer screening is actually, it actually depends on our assessment of what is our patient's baseline risk, no? And the decision on when to initiate breast cancer screening should also be a shared decision with our patients. So when we say average risk, these are women, people without prior history of breast cancer. They don't have a strong family history of breast cancer, no known genetic mutation, and no chest radiation before age 30. So for these women, so we follow the protocol for the regular protocol for screening. But there are some women who might need earlier screening or more intensive screening if they are deemed to be at higher risk. No? So for example, these are patients with very strong family history, especially those with known mutations already, or those who had prior biopsies of pre-malignant conditions. So they may have to be screened earlier. So for the average person with no risk factors, we know that screening mammography can reduce deaths from breast cancer if screening is done for women between ages 40 to 70. But the greatest benefit of screening is really for women between ages 50 to 69. In fact, yung mga recommending bodies, no, American Cancer Society, the European counterpart, and all these recommending groups, actually they have very different starting age for when to start screening. So most of them would recommend starting at age 40, but recognizing again that the greatest benefit really is yung for women between ages 50 to 69. For younger women, like yung between 40 to 45, you have to talk to the patient about the benefits of screening and the disadvantages of screening also. And you should come up with a shared decision of whether to start screening already at a younger age of 40 to 44. Again, as I mentioned earlier, some women may actually be at higher risk of breast cancer. So those with strong family history, etc. So generally, you start them with screening much earlier. So generally around 10 years prior to the when the youngest family member with breast cancer was diagnosed. No? And then when considering screening, we also have to talk to our patients about the risks of screening. Of course, there's the risk of false positive, meaning they may detect, mammography can detect lesions, of course, that eventually may not turn out to be cancer. So this can lead to more diagnostic procedures for patients, including additional imaging, including biopsy, and can also increase patient anxiety. And of course, a major concern for patients would be the pain. Unfortunately, yung mammogram can really be quite uncomfortable when it's done. But it's a quick procedure, so we have to be able to allay the fears of our patients that's preventing them from doing their screening mammogram. So what if you already encounter a patient with a mass that's suspicious for breast cancer, how is the diagnostic workup usually done? So everything starts with your history, of course. Other than probing about the mass, you also have to ask about metastatic symptoms. As we know, breast cancer can spread to other organs. So we should ask about symptoms related to the bone, the lungs, the liver, and the brain, which are the most common sites of metastases. And I think it's also important to look into their social history, because sometimes patient factors like their financial capacity, the kind of social support that they have, sometimes hinders them from pursuing diagnosis and management of breast masses. And do a very good PE of the breast, including, again, the axilla, and check for whether the mass is fixed to the chest wall or not. And do a directed PE also of the common metastatic sites of breast cancer. And if the usual diagnostic procedures that you request if you're suspecting breast cancer would be, of course, imaging. No? So the most important will be the mammogram. But for patients less than 30 years old, the mammogram is usually uninformative. So for less than 30, what we prefer is just to do a breast ultrasound. For more than 30 years old, that's when we would recommend both mammogram and breast ultrasound. For patients with between 30 to 39 years old, actually ultrasound can suffice for some of these patients. Then usually if we're highly considering cancer, then obviously the next step would be doing a biopsy. So we prefer doing a needle type of biopsy rather than open or excisional biopsy. And among the needle biopsy techniques, we prefer a core needle biopsy. So a core needle biopsy requires a specialized needle that's able to get tissue samples. So this is done under local anesthesia. Other needle techniques are yung vacuum-assisted biopsy, which is done for preferred for very small lesions. And we can also do a simple fine needle aspiration biopsy using our regular needle. So as much as possible, if we are suspecting breast cancer, we try to shy away from an open excisional biopsy. We always prefer a needle biopsy. But for example, if you already have a lesion this big, no, which we commonly encounter, then just getting a tissue sample from the mass, just doing a wedge biopsy can be performed. Again, once you get your biopsy result, it's important to always correlate the result of your biopsy with your clinical exam and imaging findings, because of course, even biopsy can have sampling errors sometimes. So if there is discordance, you have to consider repeating your biopsy. Another test that we request for patients with breast cancer would be a determination of the biomarkers, the estrogen receptor, the progesterone receptor, and HER2 new receptor. So this is an immunohistochemical test that we request from the biopsy specimen. So these biomarkers are important because using these biomarkers, we can classify breast cancer further into certain subtypes. And depending on the subtype of breast cancer, we can predict their response to particular treatments, and also it gives a better estimate of the prognosis. Among the different subtypes of breast cancer, the most favorable would be the ER positive, PR positive, and the HER2 negative breast cancer. They are hormone treatment responsive patients. And for some of these patients, we can get away with just hormone therapy without chemotherapy. And again, the problem with breast cancer is that it can spread, no? And the common organs that they spread to are the bone, the lungs, the liver, and last will be the brain. So for some patients with symptoms, even if they have early breast cancer, we would recommend metastatic workup. No? So we recommend chest and abdominal CT scan and bone scan. Although, of course, in the community, not everyone will have good access to CT scan. So consider alternatives, for example, like chest X-ray and liver ultrasound, rather than delaying patient management. Now, I would like to emphasize that requesting all these tests should not be routine. For patients with early breast cancer, you should only request for them if they have symptoms. But for patients with more advanced stages, then they should be done routinely for yung may mga stage 3 and higher breast cancer. So based on your physical exam and the imaging requested, you can now stage the patients. No? So staging is important because it will guide the choice of your initial therapy and provide the prognosis. We know that patients with stage 1 breast cancer have a very good prognosis of survival, definitely more than 90% at 5 years. But those at stage 4 will only have a survival of between 20 to 30%. Okay. I'd just like to introduce the concept of genetic testing. As we know, about 5 to 10% of breast cancers are hereditary, meaning it's passed down in the family. So it's not that common, but so genetic testing is not done for everyone. We should be selective in whom to offer this test to. So usually those with young onset breast cancer, triple negative breast cancer, or very strong family history as outlined here. So what about, I'll just go quickly through the management. So the breast cancer is managed using a multimodal approach. No? So the most important treatment for early non-metastatic breast cancer would still be surgery. So it's the primary treatment and it's the most important treatment. But even with the best surgery, cancer can still recur. So that's why we offer adjuvant treatments like radiotherapy, hormonal therapy, chemotherapy, and recently there's been a lot of development in the field of targeted therapies. So for the surgical management of breast cancer, I always explain to the patient that we consider what to do with the breast, the tumor in the breast, and what to do with the lymph nodes in the axilla, because breast cancer can spread to the lymph nodes in the axilla. So for the tumor in the breast, you can either remove the entire breast or just remove the breast, the tumor with a margin of normal tissue. So we also term this as lumpectomy or wide excision or partial mastectomy. For the lymph nodes, we can either do a sentinel lymph node biopsy. This is just taking a few lymph nodes in the axilla versus completely removing all the lymph nodes already. So you can have this in combination. So you can have a mastectomy with sentinel node biopsy or mastectomy with axillary lymph node dissection. And this is actually the most common procedure performed in the Philippines, which is a modified radical mastectomy. It means removal of the entire breast and the axillary lymph nodes, mainly because we get most of our breast cancers relatively advanced. But for early breast cancer, we can actually offer just removing the tumor with the margin of normal tissue and more limited removal of the axillary lymph nodes. So you can have lumpectomy with SLNB and lumpectomy with axillary dissection. So both of these are considered breast conservation therapy, but this requires that you add radiotherapy after the surgery. Okay, so I won't go into the details. So again, our surgical options are breast conservation therapy with SLNB or axillary lymph node dissection, a total mastectomy with SLNB, or a modified radical mastectomy. And if a mastectomy is performed, the woman actually always has the option of having the breast reconstructed. So this is what a breast conservation surgery would look like. You're not removing the entire breast, just the tumor with a margin of normal tissue. So, of course, this can only be offered for patients with early breast cancer, no small tumors. So in this type of procedure, you can preserve the breast. But for bigger lesions or for patients who prefer it, then one option would be the entire removal of the breast. So after complete removal of the breast, you can either opt for just closing the wound, so you will end up with a flat flat chest wall afterwards. No, sometimes for even bigger lesions, we cannot close the skin, so we have to do some other reconstruction method by getting skin grafts from like for example the patient's thigh and then putting it in the wound bed. For patients undergoing breast mastectomy, then we should always offer the possibility of breast reconstruction, which can be done at the time of the actual mastectomy or at a later time. Either implants or the patient's own tissues can be used for the reconstruction. So this is an example of a patient who underwent mastectomy, and then the breast was reconstructed at the same time as the mastectomy using the patient's own fat and muscle from the lower abdomen. Or a much simpler procedure would be just using implants. Now, for patients with very big tumors, sometimes we offer giving chemotherapy first, no, before the actual surgery. And this is to facilitate the downstaging of the tumor so we can do a more conservative mastectomy or even a breast conservation. Now, following surgery, depending on the risk factors of patients, patients may need additional therapy. So one form of which is radiotherapy. No? So if the patient underwent breast conservation surgery, meaning she did not have the entire breast removed, then radiotherapy is actually required. And this is what turns off most patients from, many of my patients from pursuing breast conservation surgery because they do not want to have the additional radiation afterwards. So that's why many of them sometimes opt for just a mastectomy because they want to avoid radiation. But following mastectomy, it's not a guarantee that you won't need radiation. Some patients with very high risk tumors may actually still need radiation after a mastectomy. Other additional therapies that can be given to reduce the patient's cancer, the risk of the patient's cancer returning would be giving systemic therapies like chemotherapy or hormonal therapy. So the decision whether to give these treatments or not would depend on an assessment of the risk factors in the patient's tumor. So like the size of the tumor, the number of the nodes that have cancer, the ERPR, HER2. So all these things come in and we try to consider them when deciding whether to give chemotherapy, hormonal therapy, or other systemic therapies. So if a patient is breast cancer is hormone receptor positive, then we would offer hormonal therapy. So these are just oral treatments that patients take in for an extended period between 5 to 10 years. No? So designed to decrease the levels of estrogen in the body. And then for chemotherapy, so mostly intravenous drugs given in combination, they are usually given every 3 to 4 weeks for 4 to 8 cycles. And for patients with HER2 positive disease, if they are HER2 positive, then they are offered anti-HER2 targeted therapy. And this is given for 1 year. So these are very good treatments. However, the cost can be quite prohibitive. And then, as we know, the problem with cancer in general is that even if you've given them the best treatments, there's always the possibility of the cancer coming back. That's why it's important to monitor them continuously. So the chance of the cancer returning is highest during the first 2 years. And after 2 years, there's still the chance of recurrence, but much lower, so that the more intensive surveillance is done during the first 2 years. And then less intensive surveillance between years 2 to 5, and then they go back to the regular yearly screening after 5 years. Usually it's an annual mammogram and breast ultrasound. You only request for additional workup if they have symptoms that may suggest metastases. At the same time, we have to monitor their bone health, especially those undergoing hormonal therapy, gynecologic screening, because some of these hormonal therapies can have endometrial changes. And it's important to monitor their psychosocial well-being as well. So just as a wrap up, the key message I think is that breast cancer is still a very significant health problem in the country, but it is very curable. And the key to achieving a good prognosis with this disease is really early diagnosis and appropriate and timely management. So thank you very much. I apologize for extending beyond my time. Thank you.
No problem. Thank you so much, Dr. Makalindong. Marami po salamat. Marami po kaming natutunan. Lymph node biopsy, etc. Ma'am Stella, any comment?
Yes, very loaded yung lecture ni Sheila, no? Ang dami nating natutunan. And apologies, Sheila, ha? I said clinical associate professor. It should be associate professor. Sorry for the mistake. Pero I learned a lot from her lecture. Mamaya na lang ako mag-question kasi hintayin ko si Ma'am Bibeth in her talk.
Thank you, ma'am. Thank you
Sige
po.
po. Thank you so much. So we'll call you again during the Q&A, Dr. Sheila. At this point po, we'll just greet muna yung ating mga tagapanood at masugid na taga-subaybay all the way from Marilao, Bulacan, from Los Baños, Laguna, from University of Rizal System Health Services, from Bataan, those coming in from Rizal Medical Center in Pasig, First Gen Corporation. Maraming salamat po. The PGH Department of Outpatient Services Operating Room. Nandito rin po sila, UP Manila DBMB. Not sure kung ano po yung sabihin ng DBMB. I think they are not biostatistics ba yun? Sorry, hindi ko pa alam. Need to know. Department of Rehab Medicine of Eastern Visayas Medical Center in Tacloban City. The Provincial Health Office of Oriental Mindoro. As well as FEU, Nicanor R. Reyes Memorial Foundation. CCU, Critical Care Unit and Cath Lab. Maraming salamat po. Again, Eastern Visayas Medical Center, thank you. From Quezon City, from Amando Cope College, Tabaco City and Albay, the province of Albay. Cebu South Medical Center in Talisay, Cebu. Southern Philippines Medical Center in Davao City, Davao del Sur. Mariano Marcos Memorial Hospital Medical Center in Cabugao, Ilocos Norte. And Oriental Mindoro Provincial Hospital in Calapan, Bulacan. Also internationally, we are being viewed by our colleagues from Ryan Hall Shanex Incorporated in Bridgewater, Canada, Chuanin Hospital in Taipei City, Taiwan. From, ito po may pahabol, Benguet State University, Hospital ng Binyan in Laguna, Valenzuela Medical Center, as well as those coming in from Timor-Leste. Thank you so much. From University of Hail in Kingdom of Saudi Arabia and also in Canada. Okay. For our reaction po, to be provided po someone who is, I think, well-known and also will provide po the patient perspective. She currently serves po as the Director for Creatives at TVUP, which is the television of the University of Philippines. Please welcome Ma'am Bibeth Ortesa. You're on mute, ma'am.
Okay, can you hear me?
Yes po, yes po. If you can just move a little bit closer para lang po malakas.
All right.
Yan, that's better,
okay.
ma'am. Thank you po.
Okay. It's like this. I'm a 20-year-old breast cancer survivor. I was diagnosed in November 2004. I still have the letter of my oncologist to my medical manager, Miguel Flores at the Makati Med. Sabi ng oncologist ko, at that time I was 51 years old, perimenopausal. The slides show the high-grade PT2 in the invasive ductal carcinoma, along with the focus of in situ carcinoma with comedo features. The excised axillary nodes were matted with 28/49 nodes positive for cancer in levels 1 to 2, PM3. There was evidence of lymphovascular invasion. The tumor was also negative for both estrogen and progesterone receptor assays. By immunohistochemistry, the tumor resection margins were negative. No clear evidence of metastasis on chest and liver CT films or bone scans. Baseline serum CEA and CA 15.3 were not elevated. Okay. I was turning 51 when I found out the cancer. Yes, I was a smoker. I used to smoke because when you're in college, what else do? You only have two choices. You either decide to have sex or just smoke. I just went for the smoking. My father was a lay minister and the president at that time of the Christian Lawyers of the Philippines. So we were always taught to pay it forward in whatever things we did. So what happened to me? I felt instinctively in 2004 that something was wrong with my body. I stopped smoking in 2004, and then because I kind of got overweight, kasi I was finally beginning to taste the real taste of food. So I went into boxing. I think in that short period of time, my body got to be relatively healthy, but I could sense something was wrong because I'd be here on one side and then I'd turn to the other side. All of me was already here on my left, but my right breast took its time in turning. So I went to my brother and his wife. They have a small hospital, the Olivares General Hospital, and nagpa-test ako doon. Nagpa-test ako sa Makati Med, nagpa-test ako sa Asian Hospital. Wala silang makita. But I knew there was something wrong. My instincts told me there was something wrong. So finally, may isang maliit na diagnostic clinic along Jupiter Street. And naging friend ko yung mga technicians. Kinulit ko ng kinulit. They found axillary involvement sa ilalim ng aking right kilikili. So armed with that information, bumalik ako sa Makati Med. But before deciding on what treatment to take, nagdasal muna ako. Believe me, prayers really help. Prayers really help. And then, inisip ko na ang daming binigay sa akin ng Diyos na hindi ko ipinagsintir. Naisip ko, the Lord gave me a good and loving husband, faithful. The Lord gave me the ability to be breadwinner, to be able to send 6 of my siblings, 7 kami magkakapatid, to school. Hindi ako nagreklamo. Hindi ako nagalit sa Diyos. Tapos magkakaroon ako ng cancer, magkagalit ako sa Diyos. Parang mali. Parang tinanggap mo yung mabuti, yung trial at test sa'yo, hindi mo tatanggapin. So, on the way to see my medical manager for the first time, nalaman ko na yung aming family internist was in the States, si Dr. Alimurong. So, tama-tama, tumawag sa akin yung aking producer and friend, si Kichi Benedicto. Sabi niya, may ara, kita meeting karon dugay-dugay, ha? Hiligay nun yun eh. So, I told her, yeah, but I'm going to Makati Med, and my problem is, I don't have doctors. Sabi niya, I'll call you back in 10 minutes. After 10 minutes, she called me up. And then, while we're waiting for a call, again, I was praying, Lord, give me a sign that all will be well. Lord, give me a sign that all will be well. So, he gave me a sign. He gave me a sign this way. When I got to the office of, tumawag si Kichi Benedicto sa akin, sabi niya, your medical manager will be Dr. Miguel Flores. He is the nephew of Dr. Raul Flores. He is married to my niece, Dr. Lucy Flores. Anak ng kapatid ko, sabi ni Kichi. So I went there. Again, still praying. Give me a sign. First thing that Miguel Flores tells me, your surgeon will be someone that you always have lunch with your mother-in-law when your mother-in-law visits ERAP. She is one of the surgeons of the San Juan General Medical Center. She also practices in Makati Med. Her name is Jennifer Ang. Number 2, sabi niya, your oncologist is kaklase dati ni Carlitos sa undergrad sa Ateneo. So, naisip ko yung, wow, what better signs that I feel safe. I feel like I'm going to be taken care of. So, ganun palagi. All the way yan until my mastectomy. I was given a radical mastectomy. But before that, aside from prayer, I also depended a lot on my sense of humor. I did a research on breast cancer, and I found out that breast cancer was pretty much like true love. You have it forever. So, research ako ng research. I decided I'm going to keep my sense of humor intact. So much so, na before I went to my mastectomy, they also advised me, kung meron kang paayos sa ngipin mo, magpapasta ka na ngayon. Kasi hindi na pwede yan while you're doing chemo. I left for the dentist. I was wearing a rather sheer shirt. Sabi ng husband ko, I can see your 2 nipples. Sabi ko sa kanya, today is my last day to have 2 nipples. I want to show them all. So, ganun ang attitude pretty much that I took all the way to when I was operated on. In the hospital, before on the eve, my mother-in-law treated my friends and I to a dinner at the Manila Pen. And then, bumalik kami sa hospital. And my friends said prayers for my healing. Regina Alahat, Lalakel de Vicencio, outside the family. When it was my turn to pray, I found myself praying, thanking God for everything that He gave me. Hindi ko masabing, Diyos ko, bakit niyo ako binigyan ng cancer? Ang nasabi ko, salamat po, Diyos ko, sa lahat ng ibinigay niyo sa akin. Tulungan niyo akong matawid ko ang pagsubok na ito. So, tinanggal na yun. Tinanggal na nga yung breast ko. And then, at that time, my father-in-law said, okay, I will sponsor your trip to New York. Get a second opinion sa Sloan Kettering. So, I went there with my family, my 2 kids. I was, at that time, Herceptin was not yet prescribed generally. This was 2004. It wasn't described for stage 3. Because I was stage 3C ako. Isang kindat na lang, bingo na. So I went there, and then, but before they prescribed me the Herceptin, pumunta muna ako sa international desk. We were dealing with someone named Ricardo Moya, whom I presume to be Latino. Remember my prayer na Lord, give me a sign that all will be well. Pagdating namin doon sa international desk na Sloan Kettering, Filipino pala siya. Hindi lang Filipino. Ang sabi niya, Miss Bebet, ako po si Ricardo Moya. Pamangkin po ako ni Hercules Moya na asawa ni Chichay. I mean, wow, I really felt like this is going to be an interesting time. So balik na. So I was prescribed Herceptin na tamang-tama na magiging available naman dito sa Philippines. So I did 6 rounds of chemotherapy. And then my surgeon was telling me na kaya pala hindi nakita kagad yung aking cyst sa dibdib. Kasi I have medyo malaki yung boobs ko eh. I'm a 38EE. So yung cyst tumubo close to the rib cage. They had to push it out, and that's where it hurt to try to locate it, no? So finally, balik na ako sa Manila, nag-chemotherapy, and doing my 4th chemotherapy, I was staring at my shoes for a long time. Naisip ko, bakit kailangan maging terno ang sapatos ko? If after this, yung isang suso ko, totoo, yung isa hindi totoo. Nasabi ko to sa mother-in-law ko. Sabi ng mother-in-law ko, di ba meron kang sapatos na kulay blue na kagaya ng sapatos tong kulay pula, padadala ko yung pula sa yung bukas. So for my 5th chemo, I was wearing red shoes on my left foot and then blue shoes on my right foot. And then every time I would narrate this sa mga breast cancer forum namin as a spokesperson of I Can Serve Foundation, they would tell me, the girls would tell me, some girls, young girls, would tell me, Ma'am, ginagaya po namin ang ginagawa ninyo. Yung best friend ko po nagkaroon ng cancer pero pupunta po ako sa ibang bansa para magtrabaho. Magkapareho kami ng size na paa. Sinasamahan ko siya kasi yung kaliwang sapatos niya, gamit ko. Yung kaliwang sapatos ko naman, gamit niya. Always looking forward to sharing new experiences. Then I went to radiation, 33 days yun. But before going into radiation, I was advised by someone to also consider taking acupuncture as part of my neoadjuvant therapy. Di ba kasi sa chemotherapy, I would have my chemo tomorrow, ngayong araw, magpapa-acupuncture ako. After my chemo, I would be good for 5 days muna. So, day 1, acupuncture. Day 2, chemotherapy. Day 3, acupuncture ulit. Naka-sandwich. I observed also na yung sinasabi na 5 days good ka after chemo, and then 10 or 11 days na bad ka, wag ka muna maglalabas dahil mababa ang immunity mo. Pagkatapos nun, balik na uli ako sa regular routine. But I did not follow that at once. Hindi ako naniwala sa doktor ko. Kaya tayong mga breast cancer patients, maniwala tayo sa doktor ko. Ang ginawa ko na sinabihan ako, wag muna lumabas after chemo. Namalengke ako sa wet market, nagninang ako sa kasal, tumali ako sa isang contest sa Itbulaga, nakapag-meeting sa isang restaurant where I collapsed and I had to be picked up by an ambulance kasi pala I got a virus from somewhere. I realized na dapat akong sumunod sa doktor ko 90,000 pesos later na ginasto sa ospital. Okay. So yun. Following that, radiation. The only thing that hurt me about radiation, una, yung tattoo, because they give you a tattoo to, diba, to mark the boundaries kung saan dapat hindi lumampas yung points ng radiation. But my mistake, one night, I was asleep na, I turned from my right side to my left. No. From my left side to my right, I screamed in pain. I really thought I was having a heart attack. My husband was there. And then he saw me, he checked me up, he said, it's just a surface wound. Ang nangyari pala, I was only applying lotion, yung lotion na binigay sa akin ng Dr. Ortin, yung aking radiologist, on the area that was going to be radiated. I was consulting a friend who also was going through, an American friend, going through breast cancer also that time in New York. And she said, because it's the women here in the snow-driven areas of New York, we are so used to applying lotion on our entire body when it's winter, when it's cold. That's why when I was also doing chemotherapy, talagang supple yung buong katawan niya. May elasticity. Yung sa akin, wala. Talagang yung aking, there was a thin line here na humati doon sa aking, sa aking dibdib. Napunit talaga, dry skin. And that really, really, really hurt me. Now, another thing. dependence natin sa family. When one person in the family has cancer, hindi lang siya ang may cancer, buong pamilya ang magdadala nun. I remember when we were discussing chemotherapy with my oncologist, my son, Rafa, suddenly blurted out, "Mama, you will get well." I said, "What makes you say that?" And then the boy said, he was 14 years old at that time, he said, "Because the word mother is embedded in chemotherapy. It's actually chemotherapy." So I took that to heart. And kahit na anong hirap nung sitwasyon, I lost my hair, yeah, sure, I lost my hair. At nung una, bumili ako ng wig. Kaya lang yung nabili kong wig, bukod sa mainit, parang buhok ni Annabel Rama. And then I asked my other friends, why do you wear a wig? Ayaw daw nilang tinitingnan sila dahil sila ay kalbo. So, I realized, kahit naman ako kalbo o hindi, dahil meron akong konting celebrity, konti lang ha, sinabing malaki. Meron akong konting celebrity, tinitingnan nila ako. So, tinanggal ko na yung wig ko. And I walked around bald, totally comfortable with the idea of being bald. So from there, after that, continuous in treatment. And then I joined the Kanser Foundation, and we help each other survive. We share our stories with each other. And then from then on, to 2004, from now I go to the different parts of the country. I've been to Davao, I've been to Cebu, Pampanga, Baguio, Pangasinan. And ang ginagawa ko doon, ganito. I go there without makeup, and then I apply my makeup as I tell my cancer journey. When I get to the part when I'm applying my lipstick na, naghahanap ako ng someone na breast cancer patient din, someone currently going through chemotherapy, and then in front of that person, I say, okay, magkaibigan tayo, magkapatid, sabi ko. Because if friendship is that which is brought together by common background, either kaklase mo ng grade school, kabahay mo ng high school, kaklase mo ng eskwelahan, the fact that we also went through got the same diagnosis, the fact that we share the same fears, na inisip mo, will I survive this? Makikita ko ba yung anak kong graduate? Makikita ko ba yung mga apo ko? I'm telling you, we mirror each other's lives. I will apply my lipstick without using a mirror. I will just use your eyes and the expression on your face. I always get to apply my makeup na walang lampasan. You need the desire to pay forward, because ang daming tumulong sa'yo. I cannot forget what Rudy Fernandez, the actor, told me. The one time, kasi kami dalawa nag-inaugurate ng bagong chemo ward sa Makati Med. And then at that time, my mother-in-law was hospitalized. Sabi ni Rudy, dalawin ko na rin si Tita May. So going down the elevator, he suddenly said, alam mo, Bibet, kasi he was already diagnosed with cancer, periampullary cancer yung sa kanya. Sabi niya, alam mo, Bibet, pag kami lumalapit sa akin, na hindi ko kakilala, at mukha namang hindi fan, at sinabi sa akin, alam mo, Mr. Rudy, pinagdadasal kong gumaling kayo. Sabi ni Rudy sa akin, para sa akin, yun na ang pinakamalapit na parang naramdaman ko ang haplos ng Diyos sa aking pisngi. So words can really help you. Rudy passed away, but he went in peace. Ngayon, ang problema ko na lang, kasi ako, I have cancer issues, I'm hypertensive, I'm diabetic, I'm asthmatic. I'm the woman who has everything. So, lahat ng yun, I deal with that. Just recently, malapit na ako matapos, just recently, I had a bad case of asthma because nakasingkot ako ng VOG sa Tagaytay. And then it almost got into walking pneumonia. So, ang ginawa ng medical manager ko, si Dr. Forrest, he asked me to run a series of tests to make sure na walang cancer-related issues yung dinadaanan ko. So, CT scans, x-rays, endoscopy, colonoscopy, and I'm good. Pag uwi ko sa bahay namin, sabi ko sa asawa ko, I have bad news for you. Sabi niya, what? Sabi ko, hindi mo pa ako pwedeng palitan. On that note, tapos na po ako.
Okay, thank you so much, Ma'am Bibeth or Tessa. Very ano po, no, very enthralling po kasi yung kwento po ninyo kaya hindi na po namin siya na ano. We will call in Dr. Sheila Makalindong also. We'll have one question each po para sa inyo, and then my question po really for Ma'am Bibeth would be, what would be your biggest lesson that you can share to patients who are watching this, who are also suffering from breast cancer, maybe they're undergoing chemo? What could be your message to them, ma'am?
Ako ganito. Ang breast cancer po ay hindi ang cancer po ay na diagnosis ay hindi death sentence. Kasi ang totoo, lahat naman tayo pupunta doon, no? But pag nakakuha ka kasi ng diagnosis ng cancer, para kang nakakuha ng first row front seat ticket sa unang gabi ng iyong lamay. Buhay ka pa, alam mo na ang sinasabi ng mga tao sa'yo. Buhay ka pa, may pagkakataon kang humingi ng tawad sa pinagkasalahan mo. Buhay ka pa, yung mga nagkasala sa'yo, lalapit sa'yo para humingi ng tawad. Buhay ka pa, makakatulong ka pa sa iba. At that point, when I got my diagnosis, I had already felt na hindi na ako kailangan bumalik sa pagiging aktivista. Total naman, at in our own industry, asawa ko, mother-in-law ko, we were already activists doing anti-censorship work. But when I got the diagnosis, and then I survived it, that's when I felt marami pang ipagagawa ang Diyos sa akin. Kaya bumalik ako ng full-time sa pagiging activist.
And we are all the better for it, Ma'am Bibeth. The last question po will be coming from Ma'am Stella for Dr. Sheila Makalindong.
My question is for Dr. Sheila Makalindong. As a member of the subcommittee on breastfeeding, we always say in our lectures that breastfeeding decreases the incidence of breast cancer, parang 45%. Do you agree with that? What is your take on that one?
Well, ma'am, it's not taken in isolation kasi there are other factors like age at first pregnancy, etc. So those things also come in. But it's certainly protective, but it's not an exemption. Because some patients will come in, nag-breastfeed naman ako, bakit ako nagka-breast cancer? It's not an assurance. Of course, it helps because in the pathophysiology, yung unopposed estrogen stimulation, exposure ng breast can increase the risk of breast cancer. So it certainly helps. Now, one of the pros of doing breastfeeding would be that protective effect. But it's not absolute. But, that's a thing that you can do that's beneficial for your patient with a potential benefit to you. So it should really be encouraged.
Thank you for your answer.
Okay.
Back to you, Raymond.
Yes, ma'am. Thank you so much. In the interest of time, we'll be moving on po to our evaluation poll. So this evaluation poll, we encourage everyone to put in your answers po. No? There are 5 statements and it's a 4-point Likert scale. I'll read through them and will not be closing this until the end of the webinar. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists will be prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And then finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Again, as mentioned, we will not be closing this until the end of our webinar. We'll be moving on. The sneak peek po, ano po bang topic natin for next week, Ma'am Stella?
For next week, we have HIV, the increased rate of HIV. So that's going to be tackled by Dr. Sibyl Bravo.
All right. Thank you so much. Maraming salamat po. Again, I'll take this opportunity to thank Dr. Sheila Maquilindong, the Vice Chair for Training of the Department of Surgery, the UPPGH, and then also Ma'am Beth Orteza, Elizabeth Sigyon Reyna po for Director for Creatives po at TVUP. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. So you just go to www.youtube.com/TVUPPH. You go to the live tab and you'll be able to see all 213 webinars. After today, it will be 214 na po. In the same YouTube channel, you'll also go to the shorts tab naman po, wherein we have selected presentations that we feature in snippets, maybe 1.5 minutes po, no? And we're very, very happy that may mga nanonood rin po ng ating mga shorts na mga videos. Okay, so this formally closes our webinar for the week. Magkita-kita po tayo again for another exciting topic na pag-uusapan next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.